Well, welcome everyone. My name is Lourdes Perechada. I am a dermatologist. I work at the Brigham and Women's Hospital conducting clinical research. And I am delighted to invite you today to our new session of the Virtual Congress highlights hosted by GRAPPA. In these sessions, the goal is to present the most exciting abstracts that have been recently presented at the major derm and rheum conferences. And so today we're going to be presenting the most interesting abstracts related to psoriatic disease that we're presenting at the AAD that happened in Orlando in March of 2025. And so the idea today is to present these abstracts and to discuss them among experts. So we will have dermatologists and rheumatologists discussing these abstracts so that we can have a rich exchange of knowledge and opening for interesting questions for discussion. So I am hosting this session today with Fabian Proft. So hi, Fabian.
Hi, Lourdes. Yes, it's always a pleasure being here, and especially for me today as the rheumatologist here in the panel, because I was not able to attend the AAD, and so I'm really looking forward to get the small bite highlight digest so that I can also speak and be aware of all the hot topics that were just presented, and really looking forward and enjoying the show.
So if we go to the next slide, and these are our disclosures. And Fabian, if you want to present the next slide, which is our agenda for today.
Yes, exactly. So perfect. As Lourdes has just pointed out, so we are here today to discuss the highlights that were presented at the AAD, and we have 3 different topics under these umbrellas. The highlights are presented. So, and we will always have a pair of a young Grappian together with a senior Grappa member that present these highlights and compile these highlights together in advance. And so we start with the short introduction that we are already on the way. Then we have the basic science highlights from AAD that are presented by Hannah Denbraka and that were compiled together with Sam Wong. Really looking forward to that. Then we will have a Q&A and a panel discussion, and we really endorse and invite all of you to actively participate. So if you have any questions, please put them in the chat, or if there are any burning questions or points that you want to raise, you can always also join the stage here and put your verbal comments in. And then we will have the AAD treatment highlights presented by Leandro Leite that were also compiled together with Tina Butani. And we again have a Q&A and panel discussion on this. And then we will have the clinical topics that are then presented by Gabriela Rodriguez and were together selected and prepared with Cheryl Rosen. And then we will see how much time we will have left, and we'll have insightful discussion, and are really looking forward to get your input. Which topics are of highest importance for you? Do you have any questions that you not fully understood or any comments? Please let us know in the chat. And I think without any further ado, we are about to start. And so the first part that we are speaking today, and we need to change the slides to Hannah, about the basic science highlights. Always very fascinating for me as a clinician, sometimes challenging topic. And we are really looking forward, Hannah, to your presentation, and looking forward also for fresh discussion after your presentation.
Yeah, I will try to share, but it's I hope it will share. I think you can see the slides now, right?
Perfectly fine, thank you.
Yeah, so good morning today. I will be presenting 3 significant abstracts from the basic research side. So we'll focus on some recent advances in the in this basic research. And we selected these abstracts because of their contributions to cellular mechanisms, biologic therapy actions, and also some innovative drug development approaches. So we selected these three abstracts. Well, it's one about unraveling disease recurrence mechanisms by Peng et al. And abstract about underlying mechanisms of IL-17 and IL-23 inhibitors. And the last abstract will be about AI-driven drug discovery with some exciting new mechanisms used. So I will start with our disclosures. For this presentation, we both have no disclosures to tell. And then I will start with this first study, which is about cellular mechanisms of disease recurrence in psoriasis. The full title was IL-17A/F dual producing T cells, unstable Tregs and quiescent tissue resident memory cells in clinically healed lesions that are maybe potential cellular candidates for recurrence in psoriasis. And given that recurrence represents one of the principal challenges in psoriasis management, the initial findings of this research are particularly significant. And Peng et al. Designed their investigation to identify specific immune cell populations that persist in clinically resolved psoriatic skin lesions. So what did they do? They established their investigation using 3 distinct skin biopsy samples. As they illustrate in this referenced image, they strategically selected 3 different locations: an evident active psoriatic skin lesion, the PL, a resolved skin lesion, RL, and normal appearing skin adjacent to the resolved area. It's worth noting that the definition of clinically resolved lesions present challenges in the standardization across research. We know that Rachel Clark's group previously established a definition as complete disappearance of visible inflammation after treatment. And in their study, they conducted same site biopsies before and after therapeutic intervention. On this poster, they didn't provide the specific parameters beyond this visual documentation about the clinically resolved lesions they used. Their methodology, they combined single-cell RNA sequencing of T cells and multiplex immunohistochemistry to investigate this. And I think it enabled some comprehensive profiling across different skin states, and also the identification of some distinct immune signatures. And in their analysis, they identified 3 distinct T cell populations in these clinically resolved psoriatic skin lesions that they think that might contribute to disease recurrence. The first population consists of IL-17A/F dual producing CD8 T cells located in dermal papillae. These cells showed elevated expression of not only IL-17A but also F, but also interestingly, some higher expression of cell adhesion molecules, also more linoleic acid metabolism, and some other molecules, which all can be viewed as pro-inflammatory metabolites, and all pro-inflammatory already found in literature in the context of psoriasis. And the second populations was categorized as unstable regulatory T cells. designation reflects their pathway analysis findings, which revealed upregulated genes associated also with other T helper lineages, including Th1, Th2, and Th17 cells, which they thought suggest that these cells possess some kind of plasticity, and that's why they called it unstable. And it also exhibited some distinctive patterns of lipid metabolism. And finally, they also identified quiescent tissue-resident memory T cells, TRMs. These cells were termed actually quiescent mainly due to their switch metabolomic characteristics, which indicates an ability to modulate their metabolic properties. And this maybe allows these cells to survive for such extended periods within the tissue. And that could be a particular important finding for understanding the persistence and recurrence of psoriatic lesions. In conclusion, this first abstract we thought was very interesting because it addresses the gap between clinical and immunological resolution. And these persistent T cell populations provide also insight into recurrence mechanisms, and maybe they can also serve as potential biomarkers, but also, of course, maybe as therapeutic targets to improve long-term management of psoriasis. Then we turn to the second abstract, what was called the comparative RNA sequencing analysis of IL-17 and IL-23 inhibitors in psoriasis, suppression of the IL-8 pathway and immune modulation. And we thought that this research is very valuable given the scarcity of post-market mechanistic studies on biologicals. It's also worth noting that this abstract received the honorable mention in the poster awards at the AAD 2025 conference. And what they did is they collected 10 patients on the IL-23 inhibitors, 8 for the IL-17 inhibitors, and also compared that to 9 healthy controls. They collected from all the patients peripheral blood samples and performed then a comprehensive RNA sequencing analysis. And they subsequently analyzed transcriptomic data using some gene set enrichment analysis. That enables systematic identification of some differentially regulated pathways across these different groups. In their pathway analysis, Chang Lai and the colleagues found that both the IL-17 inhibitors and IL-23 inhibitors suppressed several, I think, expected pathways, including the chemokine signaling, TNF signaling, and also toll-like receptor signaling pathways. But of particular interest, they discovered that the IL-23 inhibitors specifically suppressed IL-8 signaling pathways, and that was an effect what they did not observe in the group of the IL-17 inhibitors. This differential impact on IL-8 signaling represents a potential distinction between these two classes of biologicals. This finding on the IL-8 pathway suppression maybe explains some key clinical observations. I think the clinicians maybe know that early introduction of IL-23 inhibitors seems to be associated with longer remission in psoriasis than introducing the IL-17 inhibitors. And since IL-8 mediates neutrophil recruitment and also inflammation in the early stage of diseases, these findings maybe shine some light on why this differential effect is there between IL-23 and IL-17 inhibitors. And then we have our final abstract that focuses on a novel application of generative AI in drug discovery. It's called the oral IL-17A small molecule inhibitors designed by generative AI with biologics-like potency for psoriasis treatment. It was an e-poster presented by AAD Biopharmaceuticals. And this research represents an innovative intersection of the artificial intelligence, what is of course, you hear a lot about these days, and the therapeutic development in psoriasis. I think some of you know that I show here the traditional drug discovery pipeline. It's notoriously lengthy and costly pipeline. It typically requires 10 to 15 years and a lot of money per approved drug. And moreover, also approximately 90% of drug candidates fail during clinical trials. And you see here the different stages in drug development. Generative AI approaches are now introduced in this pipeline and can enhance the efficiency at every stage of the drug discovery. And that can significantly accelerate the development process. In Lee and colleagues' study, they specifically applied these computational methods to compound screening and hit discovery, and also some lead optimization in the phases. But overall, you see that all these new approaches can lead to significantly shorter timeline from 7 to 10 years for drug discovery. So that's a good thing. In this study, they used a computational approach where they identified in the end 4 potential small molecule candidates that demonstrated some targeted action by interfering with IL-17A or IL-17AF dimer binding to the receptor. And they, to test the efficacy, this study employed 2 in vivo approaches. The first was a quite rapid model using human IL-17A to induce CXCL1 expression in mice with a readout after just 2 hours. They also used a more established, but I understood from Sam that's quite a difficult model, the IL-23 induced psoriasis ear model, where the thickness of the ear is a measurement as a readout after 4 days. The results demonstrated some promising efficacy across multiple models. In vitro, the selected compounds effectively inhibit CXCL1 expression in fibroblasts, and the preliminary in vivo results showed also the CXCL1 suppression by some of these, I think 2 of the compounds at the levels comparable to secukinumab, what was the control. And additionally, in the IL-23 ear model, these compounds exhibited also some moderate suppression of the ear thickening. Despite the preliminary nature, these results are promising for the development of some oral small molecule inhibitors, which we think can offer significant patient benefits. Oral administration with once daily dosing can substantially improve quality of life. Additional advantages also include better treatment access, decreased manufacturing costs, and simplified storage. And from a clinical perspective, these agents may also provide some therapeutic advance through rapid absorption and also reduced immunogenicity compared to the biologicals we now use. So to wrap it up, to take to work or home, is that these studies advance our understanding of psoriasis in some key areas, the persistence of specific T cell populations, invisibly resolved lesions, can maybe provide some insights in the disease recurrence mechanisms and are like cellular reservoirs in the skin. Differential effects of IL-17 and IL-23 inhibitors on IL-8 signal pathways may guide more personalized treatment approaches. And finally, generative AI has shown some promise in accelerating drug discovery, and in this case can maybe lead to some effective oral therapies with improved accessibility and convenience. And together we think that these findings create opportunities for more targeted and also patient-friendly psoriasis management strategies. So that's what we want to tell you about the basic research part of the AAD.
Thank you so much, Hannah. Thank you so much, Sam, because I think you touched on so important points and they are so relevant also, or somehow buzzwords in our clinical life, right? When we're speaking about artificial intelligence, how we can use them, and also personalized medicine approaches. So I really enjoyed your presentation. And I think we can open up for the question and answer. I currently don't see any questions from the audience, but I think this is again time to really motivate everyone attending this session. Please reach out, ask your questions in the chat, and we will bring them to the presenters. And this gives us the opportunity to really discuss the things that are relevant for you in your practice. But Lourdes, I saw your hand up. So you already
maybe I'll start so I motivate others. But my question is, as I was listening to the abstract, so the first one is about single cell sequencing, and the second one is about blood RNA sequencing, right? And so I don't do translational or basic science, so I'm interested in those of you who do have experience. So how reflective is the analysis of blood, peripheral blood analysis in terms of what's going on in the skin, right? Should a study ideally combine both, sequencing from the skin and blood to better understand? Or what are your thoughts around that? And I'm asking both Hannah and Dr. Huang, who are the experienced.
Well, maybe I can start. Yeah, I think that we recognize more and more that the tissue is the issue. So yeah, that we need also the skin data, and that would be ideal. But in the second abstract, they did the peripheral blood as RNA sequencing. I think that's also more for biomarkers. So I think in this study, it maybe has less consequence now, but for basic understanding, I think you should have both. Yeah,
that would be ideal.
Yeah, I think Hannah answered it well. I think most of the action you might imagine is in the skin itself, but I think the main attraction of these kind of studies that we're trying to get to mechanisms of persistence, or why does psoriasis recur after treatment go away, and finding these biomarkers. Personally, I think that the skin is particularly important. But in terms of what drugs are doing and signatures, yes, these blood studies are important as well, and far easier to get the samples too, as you can imagine. And so there's a matter of practicality versus how accurately the particular sample will recapitulate what is going on in the skin.
Thank you for that.
And maybe just very shortly going on, again, giving the rheumatological perspective on this, I think with the skin, it might be easy, but when we come to the joint, the enthesis or the actual skeleton, it gets even harder. So therefore, I think to have the correlation between the liquid biomarkers from the blood, which is quite easily to access, compared to tissue, this is really fascinating. So I think having both is ideal, but also to come closer when we only have the blood available, it would be very important also from the PSA perspective. But I saw that Cheryl is also having her hand up. So Cheryl, what is your take?
I just wonder, at what point did they do the biopsy of what was a resolved plaque of psoriasis? Because I think it might possibly change. If you did the biopsy shortly after it resolved, that might be very different than if you went back to that spot at 3 months or 6 months. Because at 6 months, it would be really interesting to see if those memory T cells are still hanging around, because that really could tell you that it could come back in the exact same spot. And patients will tell you that it does come back in the exact same spot where they had it before. So I think the timeline would be interesting to know. Do you know what time they did that?
Well, they didn't. That's what Sam and I also discussed. They didn't really specify it on the poster or in the abstract, but yeah, on the picture you see that they took a resolved lesion, what is still adjacent to another lesion. So yeah, I hope that if they make it to the paper, that they will specify what they used. Yeah. Because it really makes a difference. That's what we all agree on, I think. Yeah.
Thank you.
Maybe I'll bring down another comment if there are no questions. But another thing I found interesting is like you highlight like the lipid metabolism, right, associated to these pathways, right? And so in today's era that we're talking so much about obesity and new agents coming in like from GLP-1 agonists and so on, I think that there is a lot here of potential, right, to keep exploring the association between these pathways. So do you have any thoughts on that?
Yeah, I think we start to see that obesity is also a form of chronic inflammation, and yeah, lipid metabolism also have some inflammatory metabolites, and that yeah, we need to focus maybe on both to get some better remissions also in patients. So if there's also obesity, we should also get some action for that to really also, because it also has an effect on the psoriasis. Yeah.
Yeah, we're approaching a new age where we're understanding metabolomics are add to this. So psoriasis is a very complicated disease, not just immune cytokines, but other things like short chain fatty acids have been shown to be immunosuppressive, and so it's going to get more complex, and a question of systems biology, how these many different factors integrate into a particular phenotype. But people have already shown certain lipids have clear immunologic effects as well.
And maybe also from my perspective, going rather in the direction of the second abstract, what do you think will be the clinical implications, or will there be the opportunity to have somehow a personalized approach that we test the patient blood, and then we can say, well, in this specific case, we will choose this treatment over the other. Is this the first step in this direction? And what would be your estimate when we would have some kind of clinical implications for our daily life coming out of this?
Yeah, I think that's the ideal world of in 10 years, that the patient is sitting in front of us. We can take a drop of blood. We have like a small apparatus on our desk, and then can see like what are the pathways that are active and which medicine could be the best to use. Yeah, I believe that it will be in the next 10 years. We'll get there, but we still need some effort, I think.
Might get there. One of the things that the drug discovery one, they used a surrogate model for detecting whether their drug had an effect, and just measuring CXCL1 in the blood. And that is a much simpler way. So you can imagine patients, you could just give them a single dose of a particular agent and then measure their blood 1 or 2 weeks later. You may be able to see certain patterns that would predict, oh, you're going to respond to this versus you won't respond to this. So we may not be at a point where we can just do one blood and say, oh, you're that would be ideal, but we may be able to do it after just a week or two of treatment, and then you can easily tell whether this person is likely to succeed with that, or whether she should go on to an alternative choice. So that would also be helpful, I think, clinically.
And as a follow-up question, because I think from patients' perspective, this might sometimes be a bit abstract, right? Basic research. So I was definitely wondering, like, not only for the second part, but also for the first and the third one, like how and when will it be applicable for patients? It's difficult to say, of course, but maybe to talk about and see a little bit the time frame as well. Like you said, for the second one, 10 years, but maybe for the first and third one, there's also something to say about that.
Well, it indeed is difficult, I think, but yeah, these generative AI approaches in drug discovery, I think they will speed up the whole process. But we still, yeah, it's still in the beginning. So I think we need to see in the end how much time it takes. But the first results are promising, I think. And from the first, yeah, it's difficult to say, but that's always with basic research, I know. But yeah, we need this to make the next steps, I think, because we know all the treatment we have now are not enough, or for the most patients are not enough. So we need to make progress. Yeah. But it takes some time.
I would say from the patient perspective, using generative AI to screen these molecules, the old-fashioned way of doing it, you'd have to screen millions of compounds sometimes, and then you get a few target molecules, and then you have to refine them further. This has the ability to speed up this process by 10, maybe 100-fold. And so you get newer, and obviously not every drug's going to work out clinically. There may be side effects, other things, but if you can reduce that time dramatically, you will advance the number of drugs that will become available to these patients, and you'll get better drugs, safer drugs eventually, and that's going to have an enormous impact on patient care.
And maybe just one last question again from the rheumatological perspective, because I think this is so fascinating about psoriatic disease in general, that you almost all the time have the skin preceding the joint manifestations and giving us a time window to maybe intercept the disease. And also based on the second abstract, are there any indications, because we just recently had some hints that one mode of action might be superior to the other in preventing PSA onset. Is this also something that you could, when extrapolating the data, that we will have some implications on intercepting PSA onset based on these data?
Well, based on these data, I think they did not really look at that.
No, maybe more the effect of specific, because when looking into the data, it was suggested that IL-23 has a higher effect on preventing PSA onset compared to TNF, and also compared to IL-17. And could this be somewhat explained by the data that we saw?
Well, I think that it maybe highlights that neutrophils are very important, and I know that also in PSA in the first phase, these neutrophils can be very important in the synovium. So in that way, the IL-8 pathway might be also involved in the progression. Yeah, but I think it needs some more research than this study, but it's certainly something I will watch too as a rheumatologist. Yeah.
Perfect. Thank you again, Hannah. Thank you, Sam. This was a fascinating presentation and really active discussion. So I really much enjoyed it. And I'm really much looking forward to move on and going to the second part. Lourdes, do you want to bridge and introduce Leandro?
Yes, I'm delighted now to introduce the treatment update session that has been prepared by Leandro Leite and supervised by Tina Butani. So thank you both so much for your hard work on putting the presentation together. And the floor is all yours, Leandro. Go ahead.
Thank you very much. Can everybody hear me?
Yeah.
Okay, my name is Leandro Leite, and we will present the GRAPPA AAD 2025 highlights treatment updates. This is our disclosures, and we divided the treatment highlights on 4 different trends, which are emerging oral treatment for psoriasis, new biologics with extended half-life, and early intervention on psoriasis for prevention of PSA and treating obesity with GLP-1 agonists to improve psoriasis. And we will start with emerging oral treatment for psoriasis. And the first one is icotrokinra, which is a target oral peptide that selectively blocks the IL-23 receptor, and that's what kinra means. It means cytokine receptor antagonist. So icotrokinra is an antagonist of IL-23 receptor, and the results of a phase 3 study on week 24 were presented at this Congress. And we can see as an early separation from placebo as early as and when you look at the IGA as early as 4 weeks. So we can see that the treatment arm is already improving compared to placebo, and patients on treatment, they keep improving until week 24. As we can see here, the 65% of patients achieve PAS 90 and 81% of patients achieve PAS 75. And all of that was achieved demonstrating a very good safety profile with minimal adverse events. And these are excellent efficacy levels for an oral treatment, though not superior to the most potent biologics available. There are 2 new oral cytokine blockers coming, an oral TNF receptor inhibitor and an oral IL-17 inhibitor. Both are in the development stage. And there is also a new generation of TYK2 inhibitors coming. We will start first with zasocitinib, which was developed also by artificial intelligence to create a molecule that binds better to the JA2 domain, which is selective for TYK2. And what they created is a very selective molecule. As you can see here, the inhibition of TYK2 compared to others JAK inhibitors, also including deucravacitinib, which is a TYK2 allosteric inhibitor already approved for psoriasis. So zasocitinib can provide a much higher selectivity against other previous drugs. And at this Congress was presented the results of a week 12 phase 2 study, the clinical outcome, as we can see here, 6.8 and 6.7% of patients at the 15 milligrams and 30 milligrams once daily achieved PASI 75. Also, another TYK2 inhibitor, ASK001, was already their clinical outcomes were already published, presented last year, and we can see that the better outcome was with the 40 milligrams BID regimen, but this year at this Congress was presented the patient-reported outcome, and we can see a slightly better performance of the 4 milligrams once daily regimen, which is interesting. So also there are 2 new other allosteric inhibitors of TYK2 coming, ICP 488 and D2570. They were presented also at this Congress, their phase 2 at week 12 results. And we can see at the higher dose regimens a very high level of efficacy on both drugs. And here we show an illustrative chart. It should not be taken as a real comparison, not as a direct or indirect comparison. It's only a chart created by us for having an idea what is about to come on talking about oral medications for psoriasis. Here we have deucravacitinib, which is already approved. That's its results on its phase 3 study at week 16. And here we have phase 3 results of icotrokinra as we presented. And here we have the new TYK2 drugs. So new oral drugs for psoriasis are coming with higher selective, with higher efficacy, as we can see. So take-home messages for oral treatments, they are coming more selective, effective, and safer. Clear benefits over biologics are still not evident, but on the future, low cost may play a role in expanding access to advanced therapies globally. So, new biologics with extended half-life. Last year, this company presented the ORCA-001, which is a monoclonal antibody against IL-23, which had a kind of similar efficacy compared to the inhibition of IL-17, compared to risankizumab, which is another IL-23 blocker already approved. But when we compare the half-life on non-human primates, we can see that ORCA-001 has a much higher extended half-life than risankizumab. And at this Congress, they presented the new drug, ORCA-002, which is an IL-17A and F blocker. And what they did is amino acid substitution, this YTE amino acid substitution, and what it causes is less lysosomal degradation. So they increase antibody recycling and thus a prolonged half-life. So when we compare to bimekizumab on non-human primates, we can see a much higher extended, a more extended half-life than bimekizumab. And on simulations for different half-lives of 50 days and 75 days, the expected maintenance dosing would be around every 4 months or every 6 months. So take-home messages, they are still ongoing development, but they have comparable affinity to highly effective, already approved biologics, and these new biologics can probably provide an extended dosing interval since the preclinical studies showed long half-lives on non-human primates. So, does biologic treatment of psoriasis reduce the risk of developing PSA? Well, several studies have been published on this topic with several limitations, conflicting results, and a high risk of bias. Though something new has recently emerged that is the difference between biologic classes in protecting against PSA. Of course, with a high risk of biases, as we can see here, IL-23 and IL-12 and 23 blockers having a slightly protection or against PSA when we compare to IL-17 and mainly to TNF inhibitors. Well, what is new is that this new study, recent published retrospective study, analyzed the risk of developing inflammatory arthritis in patients with PSO that are initiating biologic therapies. It was a population-based analysis that used data bank analysis, and starting on 2007, and they followed until 2023. This patient had no prior biologic or methotrexate use, no prior diagnosis of inflammatory arthritis, and no prior rheumatology visits. And what they revealed was, again, that IL-23 blockade was more protective against the development of PSA. Of course, a high risk of medical coding errors, possibility of protopathic bias, again, and probably what we need is a study that can create a direct comparison of an investigation against placebo. Since, as we will have on Pampa study that will compare guselkumab and placebo, but only for 24 weeks. And that's a problem of the study, since we probably need more time of exposition to PSO to understand the real risk of PSA. So, take-home messages: there's a growing evidence. Research suggests that psoriasis treatment may help prevent arthritis, with limitations that the quality of evidence remains uncertain and prone to biases, and different among a difference among biologic classes. Well, some studies suggest that IL-23 blockers may be more effective in preventing the development of arthritis, but they should be carefully evaluated, as the risk of biases is high, particularly protopathic biases. New studies may help to better understand this association. And finally, treating obesity to improve psoriasis. Well, that's the definition of obesity. Is one of the definitions of obesity is a chronic disease of excessive adiposity resulting in hormonal and metabolic dysfunction that leads to a change in the body fat mass set point. Well, there's a high prevalence of obesity in our patients. Around 25% of our patients are obese. And the links between these two conditions are very plausible, since obesity is a pro-inflammatory state. So it helps to maintain the chronic inflammation status that on a genetic predisposed patients can help in maintaining the inflammation and help to maintain the inflammatory damage to keratinocytes. Well, since obesity can help the maintenance of chronic inflammation and also the development of psoriasis, a hypocaloric diet that decreases obesity will decrease chronic inflammation and can improve psoriasis. Well, the GLP-1 agonists are a class of medication that mimic the incretin hormone, the GLP-1, and the mechanism of action is that they delay gastric emptying, and they increase satiety. I have a problem with this word, satiety. And there are already reports on literature when the use of GLP-1 agonists for psoriasis improved both psoriasis and obesity. So you can have patients that use GLP-1 agonists and reduce obesity and improved psoriasis outcomes, such as PASI and DLQI. What was presented in this Congress was a meta-analysis on evaluating the impact of GLP-1 receptor agonists on psoriasis, and they do reveal that they reduce inflammatory markers such as CRP and TNF-alpha, but they led to no clinical significant changes in PASI or DLQI index. New studies are coming. Together PSO and Together PSA will help us to understand that treating both conditions can provide better outcomes. And the take-home messages are that there is a strong biologic plausibility in obesity treatment for psoriasis improvement. A recent meta-analysis shows no clear clinical benefits, but future studies will provide more data to clarify this benefit. And that's it. Thank you.
That was wonderful. Thank you so much. I really enjoyed all the presentations and also very interesting topics, and some already aligned with things that we had been discussing before. So I feel free to the audience to send questions to the Q&A. I already see Sam with his hands up. So Sam, please go ahead.
Sure, very nice presentation. I really like that clinical relevance. About the obesity, there a lot of controversy about this. In part, in animal models, for example, if you take genetically obese mice, they can be quite obese, but they don't. This one group showed that they don't have increased susceptibility to imiquimod-induced dermatitis, whereas other mice, we feed them a Western type of diet or high-fat diet, they do have that susceptibility. So it's maybe partly obesity, but partly the type of diets we eat leading to effects on the microbiome in the gut. And that we and other people have done studies on that. There are clearly differences in the microbiome in the gut, and the possibility of things like leaky gut syndrome and permeability in the gut leading to enhanced inflammatory susceptibility. So more to come on that, but I think there was an Italian study, really nice randomized control study where they put people on biologics with or without exercise and change diet. And those clearly people who change their diet would benefit from, they get better treatment outcomes. So we can all tell our patients that even from the onset.
Thank you for that comment. Tina, do you want to respond to what Sam was saying?
I'm so glad. I was thinking if there wasn't going to be any discussion, I was going to ask Sam a little bit more about his research. So this is great. I'm glad he mentioned it.
Okay, I want to give Wendy the opportunity to bring up her question.
Yeah, I was especially interested also in the I don't know if it was the second, but the biological treatment may be reducing the risk of developing a PSA. I know I have a lot of friends with psoriasis, and I know that they're a bit reluctant to like take biological treatments. So let's say we actually prove that it prevents the development of psoriatic arthritis. I'm just wondering, like you guys as dermatologists and rheumatologists, if you would actually consider prescribing that if like a patient has no need for a biologic, if you would actually prescribe something like that for preventing, possibly reducing the risk?
Well, I think that probably we will never have that answer, the real answer, because as we see, Tampa study, it is created like to do a real comparison of placebo against biologic, but the problem is that many patients, they need more time to exposition. The number of patients that developed arthritis every month or every year is very low. So we need more time to really understand it's. And with the availability of treatments, I think that patient will get treatment for psoriasis in a way or another. So it's hard to understand. It's really hard to understand whether you can stop the development of the new condition. And I mean, if you work with psoriasis, you probably have seen some patient on biologic that developed a clear arthritis, and so it's really hard to have this idea. But I think sorry.
No, I think it's a very hard question that you were asking, Wendy. Still, I can understand where you're coming from, and I think we cannot really give the correct answer now. However, if I would be a patient with psoriasis being on the border of getting biological treatment or not, I think this can be a very strong argument that from the data that we know, we can surely say that compared to no treatment or compared to conventional synthetic DMARDs or compared to phototherapy, biologics in general reduce the risk of developing psoriatic arthritis. And I think if you don't have any significant burden of the disease, I would not recommend you being treated with a biologic. However, if you are yeah, unsure or on the border, yeah, maybe it could be local treatment or biologic. I think this can be a strong argument, or would be a strong argument for myself starting a biologic if you are somewhat in between.
Completely agree.
Yeah, and thank you for that. I know it was a difficult question, so I was just curious about what you would respond. But yeah, I can clearly see that it's more complex, of course, as well, and more factors play a role there.
There's this, and also there's something to add. I think it's a similar way of thinking. Is if we think about the cardiovascular risk, so it's kind of the same. So if you are in the border, if you have a patient that is already obese or with high level of LDL or triglycerides, and then have psoriasis, maybe you should be more prone to be more active in treating that kind of patients. But the real answer, I don't think we can have.
Nina,
Yeah,
you
I
had a
think to
comment, right?
I think to Leandro's point, I think this is the perfect time when you have to look at the whole patient, right? So looking at kind of what their body habit is do they have a strong family history? What are their risk factors for developing that psoriatic arthritis? Do they have psoriasis in special sites? Do they have nail involvement? So these are all things that are going to kind of push you, I think, a little bit more into the conversation of, maybe we should think about biologic therapy. And I think, yes, as Leandro mentioned, prevention, I think, is a very strong term, and it's going to be really, really tough to prove that we can actually prevent psoriatic arthritis. But I do believe that we might be able to delay the progression of psoriatic arthritis, and we might be able to, allow these patients to maybe have less severe disease if they were to develop that. So I think, prevention is a strong term, but we can definitely make an impact either way.
Maybe to offer some hope, because Leandro, you were very pessimistic. We will never get the answer you said. Maybe I'll just say that there is a space for biomarkers, right? Because particularly with PSA, if we are able to identify a biomarker for PSA, that's a good one. That can potentially help our study design a lot, right? Because we know, let's say we know this patient has psoriasis, has the biomarker, has not yet developed psoriatic arthritis. Now let's give the drug versus placebo and let's observe what happened. So let's be optimistic. We will get there.
Okay. And I think the very important question is, because even though I saw Cheryl shaking her head at one point, I think we agree that we can somewhat delay the process or ease the PSA onset with more effective treatments. I think the key question will be, is there one drug mode of action superior to the other, and should we therefore use one biologic or targeted synthetic DMARD over the other if we have high probability of developing PSA on the long-term run? And I think this is something that we can't answer at the moment, and here we all have to work much harder to get the perfect answer. And this could be also a personalized medicine approach in the future, that we say, here we have high risk of developing PSA, and therefore we are prescribing treatment A or treatment B. And I think this will be the holy grail somewhat in PSO treatment, right?
And to link that back to, our GLP-1 studies, for example, I think that, yes, the systematic review showed that maybe GLP agonists alone will not, impact psoriasis severity, but it did show that we can decrease the inflammatory burden for these patients. And so that means that our therapies are likely to work faster and better in these patients, right? If they can overcome that inflammatory load. And then the same thing with psoriatic arthritis. It'll be really interesting to know, can we decrease the disease burden for psoriatic arthritis with the concomitant use of GLP-1 agonists and our therapy? So maybe alone it's not the, magic bullet that we're looking for, but I think, adding it in combination with our other treatments is really important for our patients.
Maybe I want to bring up another of your important abstracts before we move on to the next session, which is the role of the TYK2, right? So you presented some that were presented there, and others that are under development. So I'm interested in the dermatologists in the room here, and for the room we haven't seen any data, but I know that there is data that's coming to also. But where do you see these molecules in the treatment strategy, right? with your limitations and with your advantages. What are your thoughts regarding that?
I can start. I think so far, in my perspective, the efficacy of these, for example, deucravacitinib, which is our current TYK2 inhibitor, I use it in certain cases, special site psoriasis, I find it works a little bit better. But overall, I don't think, we've been necessarily blown away by the efficacy of these drugs. So I don't think it's become a critical part of our treatment toolbox just yet. But as Leandro presented with some of these newer TYK2 inhibitors, I think we are going to be getting closer to, efficacy of biologics. Now, a question comes in safety, the balance, of course. But I do think with the development of these new drugs, I think it will be more of a conversation. I think we'll be including more TYK2 inhibitors in our treatment strategies, although right now it hasn't been crucial for us.
And Sherry, I see your hand up.
So I think I've mostly been using it in people who are not interested in having a needle in their life, because as an oral medication, it's been useful for that. I really had high hopes for this medication, but it hasn't done very well in Canada. And in fact, the company has withdrawn their patient support program. The drug is still available, but they have really decreased their interest in treating psoriasis. I know there's studies going on now for deucravacitinib in lupus and other things. So we'll see if the other TYK2s do better, and it seems like they will do better. Now, I also have patients who are on deucravacitinib, and they're doing great. I just renewed somebody yesterday. She had a PASI of 0. So everybody's different, but and you can't tell who's going to do well on which drug, which is what we've been talking about. So yeah, I've been using it in a very limited way.
And
thank you for sharing. Yeah.
Sorry, adding up on this, I think as mentioned already, we don't have the label and the proven efficacy and PSA, which is also giving us some more background. However, also when speaking about difficult to treat complex cases where we need to consider even combining therapies and having dual therapies, I think TYK2 and DOCRA with the data available, also I'm mentioning safety aspects, could be a perfect partner in crime for having dual therapy. So this is something, an outlook into the future.
I agree.
Yeah.
That's a great comment. Thank you.
Okay, I really much enjoyed the discussion. However, I think we need to move on so that we don't keep you all too long. So thank you again, Leandro. That was a perfect presentation. Really much enjoyed it. Thank you also, Tina, for supervising Leandro. And I think now we can move on for the clinical topics as the cherry on the cake of our meeting today. And here we will have Gabriella presenting, and she was supervised by Cheryl, and we all met both of you already in the discussion already, but now having the clinical topics highlights presented by you, Gabi. Go on.
Hi, good morning, everyone. We are discussing the clinical part of the AAD highlights today. These are, let me see, our disclosures. And so we're gonna start first with this abstract, sorry, just go back. And so the first one that we were interested in was this abstract that we found, the paradoxical eczema prevalence in patients treated with biologics for psoriasis. It was a systematic review and meta-analysis presented by Cavalcanti et al. They did a research on several databases. In total, they picked 26 studies comprising 32,611 patients that had psoriasis and were receiving a biological therapy. And we thought this was very interesting because we've seen it in clinic, and they were specifically looking at prevalence. And in the past, what it had shown is like it's a 1% prevalence of this paradoxical eczema reaction. And it's not that uncommon to see in clinic. And so we already know that the anti-TNFs, IL-12, 23s, 17s, and 23s, we use to treat psoriasis, and we can get paradoxical cutaneous events like paradoxical psoriasis, cutaneous lupus, granulomatous disorders, but also the paradoxical eczema. And usually the atopic dermatitis and psoriasis genetically and immunologically, they occur distinctively in inflammation pattern, and they're not often seen together. But the impact here is because eventually, if patients were responding great to their psoriasis treatment, potentially we will need to stop the treatment and then think of another one, or do concomitant immunosuppressive therapy for the eczema. And the mechanism is still unclear. We think there is a shift in the immune response, that we have more of a Th2 response inflammation that is enhanced when we inhibit any of the molecules, the IL-17, 23s, or TNFs. And this Th1, Th17 activity is suppressed in the psoriasis pathway, and then the Th2 response is more enhanced. And Al-Janabi et al., they showed in their study that they found that IL-23s actually were the ones who had the lowest risk of having this paradoxical eczema. And they saw it associated to factors like age. They saw it in older individuals, more in female sex, and a previous history of patients that had atopic dermatitis of hay fever in childhood, then that disappeared in adolescence, and then when they had the psoriasis, then the eczema flared again when they were put on a biologic. And so this meta-analysis that they did showed, on the contrary, that it was more prevalent in males, average age of 45.6. They included all the IL-17s, 23s, 12, 30, 23s, and TNF inhibitors. And it showed a prevalence higher of 2.3%, which previously was reported at 1%. And that we think that if we keep reporting this cases, probably it will go up higher, because it's something that we see in clinic, not as frequent, but it's not rare to see. The other clinical topic that we thought it was very interesting was this talk by Dr. Eluski. She talked about the differences of nail psoriasis versus onychomycosis, and how clinically sometimes it's difficult to differentiate, and she gave pearls in management and clinical differences for us to take in consideration. So in onychomycosis, she mentioned that there's a high prevalence of it coexisting with psoriasis because of the toenail dystrophy. But if we see it mostly affecting toenails, we should think about onychomycosis. And usually we'd see patients that come to us and they've been treated with a previous antifungal with no response and no previous positive culture. So that's something to take in consideration, to think about is more psoriatic disease of the nails. And for psoriasis of the nails, we find it more in fingernails, and we can see it in 50% of the patients that have skin psoriasis and 90% of the patients that have PSA. So always important to go after this other comorbidities when we see nail involvement. Affects 10% of males more than females. And then there is a 5% of patients that only have nail psoriasis. So those are the most tricky and difficult ones, because there has to be a good investigation to rule out other causes of nail changes. Often it can be associated with scalp disease. So she highlighted how we should, when we see nail changes, check for other areas such as scalp and folds and other areas of the skin that are usually compromised by psoriasis. And there are also non-specific changes that resemble onychomycosis, like the splinter hemorrhage. This we see it caused by thrombosed capillaries of the nail bed, and the hyperkeratosis and subungual debris that it's practically impossible to differentiate from onychomycosis. And so sometimes what we do in clinic is we take samples both for culture and pathology. And this is very helpful to differentiate when it's onychomycosis and nail psoriasis. And so she presented this for separated meta-analysis. They all showed izokizumab having the highest rate of nail clearance as soon as 24 weeks, which makes sense because for skin conditions we see as soon as 12 weeks, but nails take a while to grow. So probably that's why it showed improvement in 24 weeks, but it's a very early improvement. and very good to take in consideration. In terms of treatment, we do have the GRAPPA flowchart that we know, and is consistent with what she presented. And if we have nail involvement in psoriatic disease of less than 3 nails, we could think about ILK injections if there's nail matrix involvement, or just using topicals if there's nail bed involvement. Topicals being vitamin D and steroids. And in terms of the ILK injections, is something that we can try, but we can all agree, I think, that this is a little bit painful for patients, and sometimes it's not the best approach. If it's more than 3 nails, or there are other areas of involvement, or if there's PSA, we should think about systemic treatment. And it's very important also taking in consideration patients' quality of life, because sometimes if it's just nails, might not be the whole body, but it can really affect the patient in terms of depending on what they do for work and how they feel about it. So it's something that we can take seriously. And the last one we chose is this one, consistent with the previous talk that Dr. Leite did. And this was Dr. Mark Leopold, who talked about if we as dermatologists should manage obesity and psoriasis. And so he presented a broad range of studies mentioning of how obesity affects psoriasis. And for example, this first one, having a prevalence of metabolic syndrome higher in patients both with psoriasis and psoriatic arthritis. He also highlighted not only in this inflammatory skin condition, but in RA patients follow-up to 48 weeks, obesity was associated with a lower likelihood of a good response to treatment. And in patients with psoriatic arthritis as well, living with obesity, having a less likely remission in very low disease activity in psoriatic arthritis, or minimal disease activity. And this other study that I think that's the one that we were mentioning about in the discussion previously, about how patients that did a diet versus a control on TNF blockers had a higher PASI achievement of PASI 75 when they were on a diet versus the controls, which was just a 59.3% versus an 85.9% of improvement in the PASI 75. And this last one study that he presented, it was comorbid obesity and history of diabetes. So it was 2,934 patients on biologics for psoriasis that show obesity decreased in 25-30% and 30% odds on achieving a PASI 75 and PASI 90. So pretty much we have evidence of how obesity does impact the severity of the disease and also the response to treatment. And so what he proposes, what we've been talking about, GLP-1 agonists approved for weight loss, semaglutide, liraglutide, and tirzepatide, and how it's been shown that we know and that psoriasis is linked to cardiometabolic risk, increased in risk of hypertension, myocardial infarction, and stroke. And the studies of improvement of psoriasis with GLP-1s is the majority of case reports and cohort studies that show improvement. And the mechanism it proposes that it decreases the pro-inflammatory cytokines, reducing visceral tissue, adipose tissue, and decreasing monocyte inflammation and vascular endothelial adhesion. And so studies have shown reduction in systolic blood pressure, total mortality in terms of stroke and myocardial infarction. And we have the SELECT trial that shows semaglutide reduced cardiovascular events in obese and overweight patients. And so the question was open if we as dermatologists should treat it. And sometimes it's difficult because of the time of the consult, and if in the future more combined clinics with other specialists will be proposed as a possible approach, but definitely clinicians should collaborate at least with primary care providers to optimize these patients, to try to decrease possible comorbidities that can lead to other mortality issues in the future.
I was muted. Thank you so much, Gabriela, for that presentation, and Cheryl for helping her. So we are gonna open the last session of Q&A in the last 15 minutes that we have, so you can feel free to send your questions in the chat, or to, I don't think you can mute yourself back, but you can send the questions, we will read them out for you. Maybe just like looping with that last abstract that you were presenting about obesity and GLP-1 agonist, I was curious, I was thinking, Fabian, from a rheumatology perspective, have you encountered these patients in which you question yourself, like, should I prescribe GLP-1 agonists because the patient is obese, has diabetes, and I think that might also improve their joints? Did you have those considerations you feel like?
To be honest, I have to admit that I'm not very comfortable and very experienced with these new modes of action. And it's also here in Germany, at least was somewhat difficult to get these medications. What I have frequently done is referring to the endocrinologist, taking care of most of those patients, and asking, saying, well, I have here an obese patient, and I think this might be an opportunity. So I can't really speak about my personal experience that I have treated 100 patients or whatsoever, but I think it is a fascinating topic. And as Gabby just mentioned, and I think this is always a role model that I love to refer to, is in Toronto, where Leahy Eder is doing the combined cardio rheumatology clinic. And I think this is going exactly in this direction, right? Because if we are only treating, I'm treating the joint, you are treating the skin, and we're trying to send the patient away to get the diabetes or the heart disease treated, I think we will be missing important parts of the puzzle. So I think to really aim at least for more holistic management of the patient and the issues that the patient is bringing to the clinic, whichever clinic this is, I think this would be really important. And furthermore, I think we do need to have better evidence to indicate really the effect of GLP-1 agonists on disease activity. I'm mainly familiar with the PSA data, where there is almost nothing out there. We all have the feeling if we will be treating obesity as a main driver of disease outbreak and disease activity, we will have beneficial effects also on PSA activity. But at least to the best of my knowledge, this has not been proven yet. And I think this is something that the future looks really fascinating, but the future also need to show that this really is the case.
Yeah. And maybe I'll pivot to Cheryl now and hear about your perspective as a dermatologist in Toronto. How are you approaching these patients? And
I haven't yet prescribed it myself. We do a combined clinic with rheumatology, psoriatic disease clinic. And even there, we haven't prescribed it ourselves, but I actually don't think that I would, mostly we have referred to endocrinologists to do this, that we work with, that we have sort of a network with. Initially, when this all sort of began, there were very few endocrinologists in the city who were actually prescribing it, but now I think it's sort of everywhere in terms of endocrinologists providing this. And it may come if we learn more and more about GLP-1 and its effect on psoriasis and psoriatic arthritis, then maybe I will do it myself. I don't think it's difficult. I spent a lot of time talking about this medication, and I think that I would feel comfortable using it if
we're just not there yet.
If we have more information that it truly makes a difference for psoriasis and psoriatic arthritis.
Thanks. Any questions about the other topics presented in the clinical session? Leandro?
I just have something to add, is that at the AAD they created a debate. It was Mark LeBeau and I don't remember the
Richard
other.
Warren.
Richard Waring, it was very funny. It was very fun. And yes, exactly. And they were both in debating over prescribing or not prescribing and the benefits. And Richard Waring, so Richard Waring was presented the way of was presenting the benefits of not prescribing, and mostly what he said is that we need to deal with side effects, and we are not the proper kind of physicians to deal with it.
But I'm not so sure that that's true, actually.
Yeah.
And what Gabby presented
Having
was
our own debate, Fabian.
what Gabby presented was Mark Liebwald's half of the debate.
So what Dr. Liebwald also mentioned is he said, is specifically about side effects, that it's a low percentage of patients and it's mostly GI side effects that could be managed easily, and that also patients themselves, even if they have the side effect, they prefer to stay on the drug because they're seeing so much improvement. So I think it's like, even as general physicians we would be able to deal with those like GI side effects. But
I think there are also some long-term effects that we have to be careful of, right? And I think I've heard no. Sharon says no. In terms of muscular activity, yeah, go ahead.
Do we have, or are you aware of any data about the combination of GLP-1 antagonists with any biologics? Is there any data out there from registries or any prospective data? Because I have not seen those. I know that there are now studies recruiting prospectively the combination therapies, but have you seen? Because I think, as you said, it's growing and people are being treated, and most likely there will also be people that are under biological treatments. And I think this would be something that I would be really interested in before prescribing it, if it's at least safe from the perspective of combining those, or if we are getting a good effect on the activity on the sake of safety issues. Nothing out there
I
yet.
don't know of anything published. At our own site, we have a longitudinal observational study, right, on patients with psoriasis and psoriatic arthritis. We're actively collecting prospectively that data now, given the hype, because we have the same question you have. But we are not even close to having any results, because we just implemented the standardized questions about GLP-1 agonist use very recently. And when we were thinking about how to ask about this, we were considering it's not just the prescribed by the physician, right, in the clinic, that we could track down through medical records. And that's why we're doing it prospectively with a questionnaire, right, and targeted questions, because now you can look, like, Google is offering you all the time GLP-1 agonists, you know, so people are starting to take them under more alternative pathways than their typical prescription coming from a doctor at an institution. So I think there might be much more use than one thinks about it, and it will be important in study design moving forward to be able to capture that, if that makes sense.
Current problems are expense of the medication, because there are places that will insurance that will cover it for diabetes, but will not cover it for obesity. Expenses, so expense and availability is a problem also. So those are two factors, apart from its effectiveness, that have really influenced its use.
And maybe if we switch to the other abstract, the one about eczematous dermatitis, right? The paradoxical reaction. They provide an overall prevalence, but they do not stratify per mechanism of action, right?
No, they do not. No,
they do not.
Yeah.
But in your presentation, you do highlight that it might be more IL-17 related than IL-23.
Yeah, that's another study by Dr. Al-Jabi, that they found out that IL-23s have the lowest rate of paradoxical eczema when patients are being treated with biologics for psoriasis. Not so much of more IL-17s, but less with IL-23s.
Okay, thank you. Thank you for clarifying that, because I wasn't sure if I was following it right. And And from a clinical perspective, Cheryl, have you encountered those patients with those reactions? If you have a patient with, let's say, atopic dermatitis, do you think twice before prescribing your biologic for that patient that has both, right? An atopic background and psoriasis. Does it influence your management?
Where I've seen it more is a patient with psoriasis who's been on several biologics for psoriasis that, there was secondary failure at 2 or 3 years and he was doing absolutely fine. And then all of a sudden he became somebody with atopic dermatitis. And we did multiple biopsies to try and figure it out, and it wasn't psoriasis anymore. And he did not have a history as a child of atopic dermatitis or hay fever or asthma. But it was very difficult finding a medication for him once he'd switched. The standard biologics did not help, actually. Dupixent, Rinvoq, no, we had to keep going. So, but I haven't actually seen someone who had atopic dermatitis as a kid, then developed psoriasis, and then had this problem. It's more in people who never had dermatitis before.
Interesting. Fabian, Leandro, Hannah, have you experienced any of these reactions with your patients, and any thoughts about that?
Yes, I do have some cases in both cases. Actually, when in atopic dermatitis, it's kind of easier because you can change for a JAK inhibitor and then we can control both situations. But on the other way, it's harder. Sometimes we add methotrexate and we can have some kind of control. Sometimes here, I work in Brazil, and sometimes it's hard to have access to JAK inhibitors, and it's more complicated. When methotrexate doesn't help, it really hard to get
To find
another
an alternative.
Yes.
Okay, thank you. Any other thoughts? Questions? We're at the hour almost.
Yes, I think just from my perspective again here, I think I'm not able to contribute significantly as a rheumatologist, but just to wrap it up, and I think these were fabulous presentations by the young Grappians today, and I really enjoyed it, and thank you all for investing the time and giving us the opportunity to benefit from your expertise. It was really, really insightful, and also thank you to the seniors that were supervising and guiding and mentoring the young Grappians in this process. I think this is always really fruitful for both sides to get this relation and connection. And thank you, Wendy, for also making the time to contribute with the PRP perspective, because I think this was what we were discussing previously, that we are here to support the patients reducing the symptoms and reduce quality of life. And I think this is what we are all here for in contributing to this. And therefore, your perspective and giving us a different angle to look on things is really important for us as well. And we had really the hot topics, the GLP-1 antagonists, we had AI, we had new treatment modalities, and I think it was just fabulous. Thank you all for joining. And I think this is also time for highlighting the next event that we are going to come to, and this will be from the EULA, where we as the rheumatological community will meet in the beginning of June in Barcelona, and we will have the virtual congress highlights, where again, young Grappians under the supervision of rheumatological senior GRAPPA members will present their highlights and bringing them to you in your living room, in your clinical practice. And I'm really much looking forward to this. And yeah, thank you all for timing and making it possible today. And a special thanks goes out to GRAPPA administration, because Annie really is doing the heavy lifting for all these events, and it was again perfectly organized. Thank you so much.
Thank you so much, everyone, and thank you, Annie. It was wonderful.
We look forward to seeing you in Colombia.
Yes. Bye. Have a